So it was a handful of patients out of a total of 29 enrolled patients. So it came out right around 70% of the confirmed response rates, which meant that every response were required to have the confirmation on a subsequent scan, restaging scan. The specific enrollment the inclusion was that patients must have progressed on prior PD-1 or PD-L1 antibodies. So in this sense, the reason why was because we wanted to be able to conduct a study that isolated the efficacy contribution of the anti-TIGIT antibody that we were studying, Domvanalimab. So in this sense, I think that the response rate provides a signal that this specific, using an anti-TIGIT therapy, a specific anti-TIGIT therapy may have efficacy in this patient population. So when this study was conceived a few years ago, there was actually absent data on anti-TIGIT efficacy in really diseases outside the lung. We know as monotherapy, anti-TIGIT didn't really seem to have associated with any objective responses. So this was an exploratory study, and the enrollment was was fairly small for that reason. And that explains also why our confidence intervals are pretty broad. That being said, the bar is sort of low for many of our currently, based on the response rates of our currently approved post-first-line HCC therapies, which generally have response rates between, 4 to, generally the single-digit or low two-digit responses. Cabozantinib, for example, is 4%, and some of our other drugs up to 10%, but pretty small numbers to begin with. So, again, I don't think we can really we don't have any data that suggests that our combination treatment that we tested is going to be better than those other options. But it does, to me, suggest that there is activity in this population still. So I think this was born, we analyzed circulating tumor DNA in this study because we've already had some retrospective data from our institution, as well as from, published studies have suggested that ctDNA is potentially prognostic in hepatobiliary cancers. And then monitoring ctDNA can tell us how these tumors evolve, as well as potentially guide or predict treatment response. So, I think our goal here was to test this prospectively. I think that hasn't really been done or borne out in a published study today. And essentially what we saw, which parallels what we've seen in other cancers, is that circulating tumor DNA does seem to, among the patients with responses, ctDNA levels would decline. Among the non-responders, most of the ctDNA levels would increase, but not necessarily. So I think that there's obviously, our results are also confounded by the sample size was based on our clinical enrollment and our clinical endpoint. But this does corroborate that circulating tumor DNA may be useful as a treatment monitoring tool, where it's going to have utility, for example, over radiographic imaging or as an earlier time point, I think still it needs to be studied. The other most common non-imaging biomarker that is frequently used to assess HCC treatment response is AFP, but that itself is well known to be not very, may not be sensitive or specific. And in fact, a number of the patients who had objective responses never had elevated AFP levels to begin with. So it would have been, low utility to use AFP in those cases. Our study provides enough evidence to say that circulating tumor DNA should be used as, for example, like a surrogate endpoint. I think the data is consistent with data that has emerged from other cancers. I think that there's, I think the real question is going to be, what does ctDNA dynamics add in addition to just radiographic imaging? And I think that there are cases, for example, in patients who may have disease that is more difficult to assess objectively or reliably by radiologies. For example, patients who may have, smaller degrees of peritoneal disease, or patients with a lot of primarily lymph node involvement, where lymph node measurements can be confounded by, some decompensation or heart disease. Liver, by their cirrhosis is what I was referring to for decompensation. So there might be, a group of patients where ctDNA may be useful for treatment monitoring, but I think that has to be fleshed out in much better detail, because these tests aren't cheap either. And so the question is, how much more does it add? I think that in patients, for example, where their disease is very easily and objectively measured, then this may not have as much of a role. We did look at the specific, how the genomic landscape that we could see in ctDNA, and whether it would change, but we did not find any very specific gene alterations that were associated with resistance to Domvanalimab or Zimberelimab. But again, that the sensitivity of our analysis is going to be limited by our sample size. Our study was exploratory in the sense that we wanted, there was no precedent for trying to assess anti-TIGIT activity in HCC, at least at the time that we had initiated this study. Now there is, a couple of data points, including from a randomized phase 3 study. We don't know, much about what was the exact numbers, but it seems to suggest is that, at least, for example, the other drug that has been tested more extensively is tiragolumab. And even though there was some promising results in a randomized phase 2 study, it may not have borne out in a phase 3 study. But again, we're still learning more about what was actually seen. But in that sense, the question is going to be then, what would we expect from Domvanalimab when it's studied in a larger and randomized setting? And that, I think, is very hard to predict. But there are a few things that differentiate Domvanalimab from tiragolumab, primarily in their design. So Domvanalimab is differentiated from many of the other TIGIT antibodies in its FC domain, which was mutated. Which, the hypothesis being is that you would avoid elimination of TIGIT expressing lymphocytes, which could include, your exhausted CD8 T cells that are that are potentially could be tumor reactive still. So, again, we had initially proposed in our study that we would hope to see a response rate of around 20%, but that was sort of, that may have been a high bar in a sense. So, again, I think our focus is on seeing, if there was some kind of efficacy, and I think we did see that. Now the question is going to be, is there a specific patient population that could benefit from it or not? To potentially guide future studies, and that is the part that I think is we need to do more work on. One thing that we did notice is that there didn't seem to be an association between a lot of the commonly assessed baseline characteristics of our patients that are associated with response to this combo. But all the responses were in patients who had primary resistance to their prior PD-1, PD-L1 therapy, in the sense that those patients generally always demonstrated progressive disease at their first or early on to prior immunotherapy. Yeah, I think in a sense, yes. I think that we provided very early preliminary results. I think in the context of the entire field, it's really going to, especially again with tiragolumab, potentially having negative results in a larger phase 3 study. I think we have to be very cautious in terms of how we interpret our data. But in that sense, I think that, conducting a follow-up study, not necessarily on a phase 3 scale, would be very reasonable. Another difference between our study as well as the studies that tested tiragolumab is that our patient population was again the PD-1, PD-L1 refractory population. And maybe that has a role in, again, an unintended role in terms of, for us, we wanted to be able to have a study design that could isolate the contribution of anti-TIGIT therapies, but we may have also unintendedly selected for the patients that could benefit from this. So I think that warrants more testing in a larger study. Probably another phase 2 randomized study would be enrolling more patients would be a reasonable next step before we would, push for a definitive study.